So, welcome everyone. We have with us Dr. Shilpa. Dr. Shilpa is an anesthesiologist with plenty of experience at the grassroots level. She's worked with organizations like Surge and Jan Swasthya Sahayog. In 2021, she started an organization called Sangwari with a group of friends, where she found her calling in palliative care. So today, Dr. Shilpa will be sharing her experiences on integrating palliative care with primary care. So welcome, Dr. Shilpa. The floor is yours.
Thank you so much, Arpita. Uh, should I share my screen and I'll start? Is my
Yes,
voice
please.
okay? Am I audible?
Yes, loud and clear.
Okay, just 1 second. Can you see the presentation?
I can.
Yeah,
Yes.
the slides are moving, right?
Yes.
Okay, great. So I'll start off. Thank you so much, Arpita, for this kind introduction. I'm Shilpa, as Arpita said, and I'll be sharing basically my journey in palliative care so far, of specifically focusing on how we began our work, and now we are basically integration of palliative care with primary health care. Um, uh, so, uh, as Arpita said, that I have a background of being an anesthesiologist, and later I developed interest in pain management and palliative care. So I trained myself in that, and my learning has been that, however, number of degrees we might get, but the greatest learning comes from doing. So whether you have a degree or not, but hands-on experience actually teaches you much more than any of the courses that is there. That's my belief, firm belief, I guess. So I'll begin with briefly about Sangwari, which is the organization that we work through. So it's a not-for-profit organization, basically a Section 8 company, which was established in the year 2020. And the geographical location is in northern Chhattisgarh, in a district called Surguja. So, the context is that the largest percentage of people living here are, of course, farmers, but also more than 50% of the population is Adivasi and marginalized in various aspects. Um, so this is where we work. The picture on the right that you're seeing is a zoom in picture of the district, and there are three spots that you see, the triangle and two blue circles. These are the places or locations where our community-based clinics are located. So we provide comprehensive primary, and I would say in certain aspects secondary level of care for certain illnesses in places which are nearer to people. They are away from the district headquarters, but nearer to people, closer to people. And this is supported by a community health program. So we have health workers in the neighboring villages, which help. So these two actually go very well with each other, and they support the clinics and the community program work support each other in various aspects. So palliative care is one big focus area of Sangwari, but we work on other areas as well. Coming on to a little bit of the health situation right now in Sarguja. So as you can see that the health indicators which are commonly used to quickly understand an area, life expectancy, infant mortality rate, under 5 mortality rate, or maternal mortality rate, are these all are pretty on the adverse side when compared to the national estimates. So this slide actually quickly gives you an idea that the maternal and child health agenda and the overall health is basically poorer than an average Indian. And and also we get to know that the maternal and child health agenda, which has been the priority of the National Health Mission and the Health Department, is still unfinished in this area. And when we look on to this slide, which is basically the global burden of disease, the top 10 causes of death. Uh, as per based on diseases. So when we compare it with 1990, so in 2 decades, the biggest killer has been the chronic illnesses. So there has been some control in infections, so which has led to more mortality through cardiovascular and other respiratory illnesses. So this is basically laid on the unfinished maternal and child health agenda. And this and when we actually compare it and we zoom in and we look at Surguja, and these are the causes of death which we had actually found out from the data which the ASHA collects. So here also you can quickly see that the bigger area, the biggest chunk is being taken by chronic illnesses, or which are the lifelong illnesses which remain with you and need to be cared for throughout your life. And this reduces the quality of life, not only of the person, but also it increases the burden of care on the family and the primary caregiver, which usually are women in Indian setting and even globally. So, quickly looking at the current status in India with respect to palliative care. So, there are a lot of studies and estimates which tell us what is the current need and how much is the unmet need. So, one such study suggests that nearly of the 10 million people that die in India every year, three-fourths actually experience avoidable pain and psychological distress in their last phase of life. And these are the people who could benefit from an intervention like palliative care, uh, but the access is extremely limited. Another one says that around 5.4 million people per year need palliative care in India. And out of these who need, only 4% have access to it. So you can see that although we are well across third or fourth decade when palliative care was introduced in India, but still the access is really poor. And on top of that, when palliative care is not provided, not only the family and the patient suffers physically and psychologically, but it also adds to the social and the financial burden and financial distress. Because one such paper suggests that 55 million Indians are pushed below the poverty line every year because of catastrophic health expenditure, because of the chronic illnesses uh, and the care that one of a family undertakes to uh, the healthcare that one resorts to. It leads to catastrophic health expenditure in millions of people in India. And another report suggests that India ranks lowest on the quality of death index in a report which measures end of life environment in 40 countries. So not only the burden of chronic illnesses and lifelong illnesses has increased, which has led to avoidable pain and suffering and psychological distress. It's leading to financial distress as well. And it also is deteriorating the quality of life as well as the quality of death in India. So this suggests that the unmet need for palliative care is enormous. And when we look at the Western model of care, which is more specialized, uh, more academic, institution-oriented care, that level or model of care would not work in meeting this need. It has not worked in other um, diseases and illnesses as well. For example, in maternal and child health, also India had resorted to a very strong primary care network of healthcare workers in the form of ASHAs, and they have been the core end point delivery of such a program. So, similarly, in palliative care, just as enormous need suggests us that probably we will never be able to meet this need if we only stick to the specialist and the uh, big academic or tertiary quaternary levels of institutions taking care of palliative care. So it has to reach, if it has to reach the last mile, it has to be integrated in the primary healthcare system itself. So we can see that there has been increasing number of people who have non-communicable diseases, like which means NCDs, and uh, this burden of provision of palliative care, this unmet need is significant. This leads to poor mental health, not only of the patients, but also their families, especially the primary caregivers, which are mostly women. This also leads to early deaths. It leads to disability because the chronic illnesses are not caught early. They are only diagnosed at a later stage, which means that the person already has some complication associated with that chronic illness, and this has led to disability and reduced further the quality of life of that person. And it causes high out-of-pocket expenditure or chronic catastrophic health expenditure. Also, because our healthcare system is still adjusting to this enormous need of taking care of the chronic illnesses. In a place like Chhattisgarh, the healthcare system is actually not well prepared to take care of this burden of chronic illnesses, and the system is still adjusting to it. So, on top of that, when people try to seek care and public health care isn't sufficient to meet their needs, they resort to private health care, and this leads to higher levels of expenditure and uh, which go hand in hand with poor access to quality healthcare. So this is how we began actually. We did not start with cancer, which normally is associated very closely with palliative care, that uh, only cancer patients need palliative care. But we began with illnesses which are, very infectious, very, Central India. It suffers there was a big burden of an illness like sickle cell disease, uh, which which is endemic to this area, and it is not diagnosed. It becomes sort of like an invisible disability requiring multiple sessions of blood transfusions, and the healthcare system was failing to prevent or relieve this suffering, and they were resorting to private hospitals which only did symptomatic care, and they were not being provided curative treatment. Similarly, in COVID-19, we began our services in the ICU, and there we felt that we won't be able to save all lives. The people who have uh, severe levels of illness and complications need palliative care, need that level of relief in pain and respiratory distress, so that which was not available at the time in the tertiary pub care hospital in the district headquarters. So this is how we stumbled upon palliative care, and we realized this need. Also, an illness like type 1 diabetes, where a diagnosis like this, which requires daily 2 or 3 injections, uh, it just means that the family, a very average family here in Surguja, will not be able to afford the care, and the person would land up in complication, would become blind, would become bedridden in times to come, and would die. Uh, instead of having a normal life, had that person been born in any other part of the world. So that's the reality, and this is how we began with palliative care here. So my learning has been that palliative care basically has been defined variously in academic circles and literatures by various health institutions. But I strongly feel that any intervention that reduces the suffering of the patient or family is palliative care. It definitely does not need to be limited to the conventional diagnosis. For example, cancer, people, there is a myth that people only understand that cancer illnesses only need palliative care, or even only end of life times only need palliative care, but that's not true. Palliative care, the biggest benefit is when a person or a family is integrated at an early level at the time of diagnosis of the illness. That's when the family, uh, the person, the family, and also the healthcare system is benefited, because the cost of care comes down not only for the family but also for the organization or the system that is providing it. And I'll discuss about this more in the coming slides, how the cost reduces. Palliative care also means sometimes that it does not only mean to stop all curative treatment or to stop chemotherapy, to stop surgery. It sometimes means to improve access to curative or standard treatment, especially in the context where healthcare systems are not developed enough to provide this curative care in the first place. So the definition of palliative care needs to be adjusted to the setting that we are practicing. It means very different in Western countries, in a place like Delhi or Kerala, but it means it has to be adapted to the context. And in the context of Chhattisgarh and especially Surguja, this is what I think I have learned, that it need not be limited to any diagnosis. Rather, uh, so thus our goal was, when we began this program, is to improve access to quality palliative care, especially among the marginalized tribal, rural, and urban poor populations of northern Chhattisgarh. And this is how we started. We started a pain relief and palliative care clinic in an urban primary healthcare center, which is a public healthcare facility in Ambikapur, which is the district headquarters, and also similar provision of out of OPD, home visits, and teleconsultations in all the three clinics which Sangwari was running. This was the service that we started with, and this is the current scope of practice right now, that we provide through Sangwari. We provide outpatient care at all three clinics. There are home visits, tele follow-ups. In the Medical College Ambikapur, we have another pain and palliative care OPD where oral and IV morphine also is available, and interventions related to chronic pain are also being provided there. Of course, we have continued the OPD in the urban primary healthcare center in Ambikapur, started home visits in urban setup for the urban poor, and had provided made available oral and IV morphine in this through this setup also. uh, and In terms of providing technical and training support, we have also reached to district hospitals in other districts, for example, Jashpur and Surajpur. And through our direct service delivery, we collate all the experiences, the learnings, and through documentation, research, and advocacy, we are reaching more and more places. So this is the current scope of practice. Now, coming on to who needs palliative care, as I said earlier, that there are various, scales, or there are various criteria which are being usually shared. There are tools which tell you in which diagnosis, when does a person need palliative care. But for me, to make it simpler, if a person who is not trained as a doctor needs to understand that who needs palliative care, then the definition is pretty simple. Uh, a person who's dependent for self care, or any person who has more than two chronic illnesses. For example, a person who has a sickle cell disease and also has rheumatoid arthritis, right? Or a person who has sickle cell disease and has type 1 diabetes. And we have such patients in our care. So such person will not be able to do well with the conventional system of care that is being provided either in the public health system or in a place or through an NGO or through a private setup, they would need palliative care. Also, another definition which actually fails in the current rules that I have gone through is that it is mostly individual focus. It doesn't talk about what a family goes through. Because in my experience, any illness or any tragedy for that matter is being handled not at an individual level in a village. It is being handled by a family. So a family has to have that resources, whether it's in the form of HR or staff or money. It has to be with the family has to be well, adorned to deal with that problem. So for me, a family with two or more than two people with chronic illnesses needs palliative care. This actually is quite embedded when we deal with HIV because sometimes the whole family has had contracted the illness. So, but not quite for other illnesses. So this we have found in a lot of our patients that one person has rheumatoid arthritis and the other parent or maybe somebody else in the family has stroke. So dealing with two chronic illnesses at one time, again, the current healthcare system isn't developed such that it will be able to take care of that automatically. So that would need focused care in the form of palliative care. Also, I would say that the person who's not currently dependent but has a progressive illness which will make the person dependent in times to come would also need palliative care and should be integrated early, especially in the primary healthcare level, because then that's when we would be able to provide them the most benefit. Again, if we go by illnesses, so in our setup, uh, we most of the patients who need palliative care are non-cancer patients, and out of that, the biggest chunk is I would say stroke and other neurological illnesses, whether it is in the form of epilepsy or movement disorders or trauma is also pretty common here. So traumatic quadriplegia or paraplegia or unexplained nerve or muscle disorders which lead to weakness and person being dependent is the a one big chunk of illnesses which would require palliative care in a setup like Chhattisgarh or in a place like Chhattisgarh and even in rural urban areas in India. Uh, Sickle cell disease, as I said, is endemic to central India. So this illness is also another big area, and then various organ failures, tuberculosis, cerebral palsy, or other developmental delays, and various congenital illnesses, because many illnesses in children also would require an intervention like palliative care. And of course, HIV. And I would say that this list is not exhaustive. And as I said, that in Sangwari, at least we do not limit ourselves to these illnesses, and we go by this criteria: who needs palliative care, and that's when we decide that a person or a family needs palliative care. So going on to how design of our program, what we did was that we began with one person or two people team going and providing whether outpatient care or home visits to people who would require palliative care. We collated our learning and the needs of the patients and the resources which were available to them or to us, and then converted all of this into programmatic inputs, in whether it's in the form of forms or templates. Initially, they were designed for doctors, and then they were simplified, and they were, basically made into a format so that a nurse or a mid-level healthcare worker can take care of that. So this is how we began. And then we combined a list of instruments, medicines, nursing supplies, lab supplies into a kit, which is appraised yearly, and this constitutes the home visit kit, which is a necessity for this to deliver this kind of service, considering that home visits are a big area of delivery of palliative care, and it's the core of palliative care to provide care where the patient is, where the person is, instead of asking them to come to a setup which come to a place which is not theirs, which is foreign to them. So care provided to them where they are located, where they want that care to be provided, is the essence of palliative care, and home visits form a very, very important component of that. And coming on to the team, so as I said, that we began with one person, one doctor who was interested in providing palliative care, and and the area that we are working, it's extremely hard to find people who are already skilled uh, in any aspect of care, because as I said, the quality of educational programs is such that we have to train most of them on the job. And this is how we began to train our nurses, providing them with hands-on experience, training on the job, and then, of course, holding specialized training programs for them, so that they'll be able to handle this responsibility and take it forward. And I would say for a setup to deliver palliative care, it has to be a multidisciplinary team. And instead of looking at it in the form of people, or or in the form of specialization that it needs, I would look at it in the form of roles that it needs. For example, it needs one person who is trained in some nursing skills. And it also needs a person who some level of skills in social work, so that there is knowledge and skills in linking a person or a family to a government scheme. It also requires a community member or a mid-level health worker or community health worker, which belongs to that local area, so that the care can be owned, or most of the care is being handled by that person, and they are able to navigate it better. Another important role is one of a physiotherapist, especially in our setting, as I told you that majority, one big chunk of illnesses which require palliative care is neurological illnesses, and even in patients who are bedridden of any other illness. Physiotherapy is extremely important because it helps reduce not only physical suffering but also helps in rehabilitation. It helps to provide a lot of complications, which might happen with time if they are not provided. So I would look at it that one must be adaptable. For example, in our setup, we taught our nurses in some basic physiotherapeutic skills, because we had extremely difficulty in finding a trained physiotherapist who would be willing to be located there and work full time. So depending on one's context, we can choose people who can be trained on these different skills and have those skills in your team. So Sangwari's model of care has been to look at disease-related care, social support, providing psychological support, and of course then rehabilitation. And the most important thing is to keep the patient and the family in the center, to look at what they want and include that in their plan of care and implement it. So if we go on to the details, so that's how we started integrating palliative care at primary and secondary levels of care in all our clinics, which are located nearer to people. Any person that comes, and I told you that we are not only providing palliative care, we are not a standalone palliative care center. We provide care for all primary healthcare illnesses. And at the time when they are being seen by not only me, by other doctors, by nurses, they are able to identify people who need palliative care, and that's how they are integrated, and that's how they are, in a way, allotted to palliative care. They are registered for palliative care, and then only we decide whether that person needs home visits, whether they will be able to do well with only outpatient care, with tele follow-ups in between, or mostly home visits and some OPD visits, and some permutation and combinations in that area. Sometimes they also require inpatient care. Uh, and that we navigate through, linking them with the government healthcare system presently. And third aspect is the assessment of the social and psychological aspects of suffering. So in our team, as I said, that social worker is an integral part of our team, and any person who requires palliative care goes through that screening and is provided that level, that care. Psychological aspects of suffering are also assessed in very close to when they're registered. Within 3 months, we try to screen them for common mental health problems, for example, anxiety and depression, and provide support for that, whether it's in the form of patient education, family meetings, talking to them, mostly listening to them, and also if it requires psychiatrist help, then we have a teleconsultation with the psychiatrist, and we start them on medication as needed. Uh, yeah, and then fourth part is to engaging with the caregivers, not only educating them on how to provide care on a daily basis in their homes for an illness which is foreign to them, which they understand very little of, and elsewhere they are not, being taught in non-medical easy terms on what they are dealing with. So this is where our nurses come in, and they do it beautifully. They spend time with them and not only teach them to take care of the patient, but they also teach them how to take care of themselves, because caregiver exhaustion is extremely common in these settings. Um, and they have very little support on their own in their own community. So, listening to them, taking care of their own health, um, or maybe just as an access of venting out is has been one of the core components of care that we provide. Then, as I said, that linking them to social support, linking them to necessary public health or social schemes is important. For example, a person with sickle cell disease is automatically being recognized as a disability, and once that disability certificate is made, they are also eligible for a monthly pension, and these are different in different states. So this is in a community like a rural tribal community like this, linking to public health and social schemes, whether you call it social protection, whether you call it social prescribing, are extremely important, because their own social, the structure that their own social, I would say, capital is very, very poor and limited. So this forms an important part of the care, and then improving their quality of life through provision of aids such as wheelchair, which improves mobility, diapers, dressing materials, air beds to reduce or prevent bed sores, has also been an important component of care. Uh, then disease-related care, mostly what we do is that active screening for pain, and any person who has moderate to severe pain is being treated in priority, not only in our clinics but during home visits as well. Availability of morphine is ensured and it's being provided so that they not only that reduces their pain, but also it's uh, safely managed and prevent the complications that one might have. Then screen for other common symptoms depending on the illness uh, is also taken care of during disease-related care. Um, then we discuss if there is a need, the case is discussed with the team of experts. A plan of care is made, along with discussions with the family, especially the people who are the decision makers in the family. There's a plan of care is made, goals of care are identified, And we another important component here is communication of bad news, because many people who come to us have also went to various other healthcare providers and they have been diagnosed. However, the diagnosis has not been communicated in a manner that they understand. And if they don't do that, if they don't understand the diagnosis and if they don't understand the prognosis, for example, an illness like multiple sclerosis, or an illness like uh, you know traumatic quadriplegia, or an secondary metastasis which has caused a paraplegia. If the prognosis is not discussed, uh, the family or the person tends to go to other providers and go on a doctor shopping or a hospital shopping till the time they feel that I have met the cure, because um, they think that it is the facility or the provider is the determinant. However, if they understand that no matter where they go, the prognosis is going to be the same, only then they would stop this this core need of searching for answers outside and searching for cures outside. And because one always hopes to uh, listen that this disease is curable, instead that there is nothing can be done for an illness. So it's extremely important, and this is important because as long as they continue to go elsewhere, they uh, unfortunately there is a um, uh, I would say the market is such that there's a tendency that the people um, who are on the uh, lower levels of education, who are not that smart on dealing with understanding what the care is being provided, who is the person, and who are otherwise also marginalized. Uh, so they don't understand, and then there's a financial burden which is added, and that adds to the out of pocket expenditure, and it leaves the family impoverished for generations to come. So this is an extremely important part, and it needs to be given that much importance, especially in our context. Another important aspect is advanced care planning, which means uh, communicating with the family well in advance. What the disease trajectory is going to look like, what level of care the person would need, for example, in another 6 months, in another year to come, so that the person and the family are both prepared and are to deal with it mentally, psychologically, as well as in the sense of resources that they have at their hands. So during home visits, as I said, that we provide patient-centric care. There is a medical assessment of the patient and the family. We relieve physical symptoms, specifically focusing on pain. We provide medicines and other nursing supplies. For example, a person who has a chronic wound. Uh, it is extremely unlikely that the person would be able to go to a healthcare facility every day for dressing. But to maintain that dignity, they need daily dressing. So we provide dressing materials. We provide the necessary, the gauze pieces and the bandage material, sterilized ones, and also the medicines which needs to be applied, how to clean, how to apply a dressing, and that all is taught, and these aids are provided to them at their homes. If there is a need that a lab sample has to be collected, that is collected from their homes only, and the report is being provided on the next day. And if there is a need in titrating the treatment or altering it, then nurses and the doctors team do that. As I said, that mental health screening and support both for the patient and the primary caregiver. We are doing that not only in the OPDs but also during home visits. So we screen them for anxiety and depression, and if we find such any of these problems, then we make a plan to address it. Caregivers are educated to care for the patients at home. Social workers are also either going Or sometimes what happens is that the nurses are basically trained in common 3 to 5 schemes, and they are able to provide or at least link them to a social worker so that the family can avail such benefits. And if there is a need, they can come to the OPD or they can go to the district hospital and avail those benefits. As I said, that rehab aids are provided. Spiritual support in the form of um, identifying areas of their spiritual distress, linking them to suitable community members who can address that, is one another area of support. There are times when we have provided end of life care at home. This becomes extremely important when we think that the person is going to deteriorate. And if we have communicated with the family well in advance and they have decided that the person does not need hospitalization, does not want to end up in an ICU, so that's when we prepare well in advance, and we provide them support so that they don't feel that they're on their own, and they don't get there are no alarms there, and they're well prepared for that journey. And our nurses and social workers, and if needed, a doctor is also available for teleconsultation in such scenarios. So palliative care is an area where the care is not stopped if the person dies. It continues beyond at least 3 to 6 months after the person has died, because we are not only taking care of the patient but also the family. So we provide home visits during the bereavement period also, and we identify signs of severe mental health problems among the family members, and we continue to be their support and provide them treatment if needed. So coming on to the numbers at a glance, so far we have provided outpatient care to nearly 9,800 patients. So these many home visits, around 105 patients have received oral morphine without any major complication. Safe use of oral morphine to reduce pain in severe pain, especially for cancer patients. Then tele follow-ups or teleconsultations have been provided. Total patients enrolled so far in palliative care have been 530 or so. And so these are the numbers at a glance. And we have actually analyzed a subset of these, around 235, and we found that 50% of them were women. And the age range was also quite diverse, from 1.5 years to 87 years old, and 67% of them were tribal. And as you can see that many patients who require palliative care belong to the working age group, or the so-called productive age group, from 20 to uh, 55 or maybe 60 in rural areas. Uh, so many patients belong to this age group. As you can see, that almost 50% of them are not educated, and they belong to either poor or very poor households, most of them. Uh, and many of them have availed 43% have availed a loan, and the mean amount has been around 66,000. Out of these, 9 have sold an asset, whether it's an agricultural land or livestock. And this actually shows us the financial distress that a family goes through. Coming on to their quality of life, this is one scale of functionality which was earlier used for cancer patients, but because it is a simple scale to administer, we can see that close to 50% of our patients were either predominantly dependent or completely dependent on their caregivers. So this just tells us the unaddressed caregiver burden which is there in our rural households. As I said, that cancer usually forms only one chunk of an illness, but I must say that this is not a recent analysis. So if I go by my experience, the non-cancer patients have crossed more than 50% right now, and a big chunk of them have been stroke or neurological illnesses. Another chunk has been sickle cell disease, type 1 diabetes, or rheumatological illnesses are also another component. So coming on to the supportive aids which we have provided to improve quality of life, we were actually quite apprehensive whether a commodity like a commodity would be accepted in a rural household, and we were very surprised that actually people were demanding it. We recently had a program in during the palliative care day celebrations, uh, and where there we held an exhibition of all these devices and who needs it and when do we need it and how to use it. Our nurses were basically doing that demonstration, and we found we were very pleasantly surprised that many patients and their family members had come to us that whatever you just told us, we think that our patient would also benefit from a commode chair. Can you provide it? So people are actually they need it and they are using it. And if they don't have the commercial variety, they are making it on their own. They are either making a hole in a chair or making it out of an old unused wood material, making it on their own, or using making a hole in a cot, so that a person who is bedridden is able to uh, uh, you know, basically uh, relieve themselves in a dignified way. Yeah. These are some of, as I said, that just to show that there is a demand and there's a need, unmet need, even in rural household for such devices. But these are expensive. These are not available in the public healthcare supply, at least not all of them. And while there's a need for innovation also here, that if we can make them more, inexpensive and more effective versions which are more suitable for a rural household, there is a need for such innovation. So just to show you the devices which are commonly being distributed and how our community is responding to them. So linkages to social welfare schemes for social worker is an important component, as I said, and they are identified through a screening form both during the outpatient visits and the home visits. Another important component of support is because a person who has an illness only can understand what one experience, what one goes through. And sometimes we as doctors tend to become experts on a subject, never having lived a day with that illness. So we believe that a person who has an illness is the expert on that. So we try to link them to each other so that they can provide support to each other. They can discuss their problems with each other. They can provide solutions, or at least provide a lending and sympathetic ear, uh, because they would be able to empathize with each other better. Another important function or objective of such meetings is to understand that you are not the only one. Sometimes an illness like diabetes at such a young age can leave people feel isolated. Why me? Why only me? So when people see that there are other people who are dealing with such an illness and they also have that illness, and how are they dealing with it, so that reduces that sense of isolation. It gives them a platform to connect to each other, to reduce their social distress, and also provide practical solutions. For example, how to store insulin in a household which does not have refrigerator. So this has been another component that we have started. So we have basically started this with sickle cell disease, with type 1 diabetes. And also about a year ago, we started with parents, for parents who have children with either developmental delay or illnesses like cerebral palsy, because uh, the burden of care for them is so much. And I would say there also women share most of the burden, and their the care that they have to give has no end, like they have to be the caregiver 24/7. So they have no time at all to themselves. So this sort of becomes like a day for them where they can, in a month, every month they are able to go out of their house and engage in not as the mother of a person, but as a person, and connect with another mother. Yeah. So this is how we started these peer support groups. Another levels of support which are required by such uh, patients and category of people are travel support, for example, from their homes to our center or a referral center or a diagnostic center that we are sending them to. Because in at least in Chhattisgarh, we don't have state transport and we don't have many means of public transport. So this forms an important area where out-of-pocket expenditures happen. Another one is the referral support. For example, for an illness like rheumatoid arthritis with high disease activity, and they require higher level of care. So we have identified specialists and we help them connect to various facilities, whom to go to, which room to go to. And sometimes there are people who are, identified within that facility who travel with them within that center, so that they don't feel lost, and the purpose that they were referred for is being completed. And this actually improves compliance rates also. Then nutrition support for some people who, for example, who require a high protein diet, or especially in tuberculosis, in elderly, in people living with HIV. Then linking them to opportunities where they can be, employed. For example, in our team only, we have 6 such recruits which have been recruited from either they were patients themselves, or they were family members of a patient who had an illness which required palliative care. Similarly, there are many children who drop out of school, and we help them connect uh, again with their education by either through open schooling or regular schooling in 10th and 12th, and even after that. So this is a letter which was actually written by one of the family member, where we provided end of life care, saying that अंतिम समय में अच्छा समय बिताने का हमें भरपूर मौका मिला. So I was just to stress that good quality of death is possible in primary healthcare setup through support, through minimal support by a dedicated team. These are some of the photos of our patients, which were identified by our health workers only in the villages. The lady on the left had stroke and was unable to, was basically not able to get up and walk, and was disabled. And because of the poor social support, and people in her family had to go out to earn a living every day. So our team decided that she needed more dignified care and helped provide that to her in some way. And the this boy on the right is was suffering from type 1 diabetes since 5 6 years, but the family was not able to afford the care, and he was left bedridden and blind. And this picture is after 1.5 years of care, that he was able to walk, he was able to see. In fact, he wanted to join a job. So, just to let you know what is possible with palliative care. And few other glimpses from our field area, where we held a few sessions on essential narcotic drugs. This is Dr. Raj Gopal on a webinar in the medical college in this area. Our home visits, teaching caregiver how to do a dressing, and so on. Another big component of palliative care, especially in primary health care integration, is the involvement of the community. And although we are dealing with uh, some situations which are extremely limiting, we still find examples where the community has owned the level of care in some way. And for example, a person in the village takes the responsibility of bringing patient either through their own vehicle or through some other vehicle where which they are using, and bring them together so that um, they reduce that burden on the family or the patient. Sometimes there are people who lend money to people who are not even related to them, and they have no hope of getting that money back. But they are doing that because they see that the person is left alone sometimes. Many elderly are living alone because they don't have children, or the children have left and sort of abandoned them. And so a neighbor or a helpful neighbor or any other villager is providing them with this help. Also, sometimes they identify and they refer them to our nurses through our community healthcare workers, or our home visit team when they visit the village. Sometimes some villages or even panchayats are taking care of food support for a person who's not able to cook and doesn't have the means to avail food in their own capacity. And as I said, that these peer support groups have also formed a sort of a network of support for these patients, because these peer support groups are not doctor or nurse led. These The patients themselves are taking the lead in this. They decide the agenda of the meeting. One of them is a secretary, another is a treasurer, and they run WhatsApp groups and they support each other in that. There is information sharing, there is news sharing, there is a lot of basically support. Sometimes they have to come to the clinic and they live nearby, so they come together. So these kinds of things are also happening, and this actually forms an important part of community ownership of palliative care. So we recently we did a qualitative, basically, evaluation of our service, and we had a third person interviewing the patients and their caregivers on what they thought of the care, because uh, we thought that is important, that this care must be, our program should reflect the values that our patient and the families hold dear, and we should include their inputs, and it should be, that's one way of making it more people centric. And what we found, that they really accepted the service. They found value in care at home. They said that providing care at home is affordable because they don't have to spend money on bringing the person to the hospital every time. They really appreciated the social support component because they could avail various government health schemes which were earlier they were not able to. And I also found that there's a lower threshold for satisfaction. And when we asked that, do you have any suggestions? So many of them were saying that you're already doing so much, and they were not able to, they were not giving any new suggestions. And another one was that the impact of the devices, and it not only improved mobility for the person but also improved the quality of life of the caregiver. And sometimes they're demanding additional service. For example, they said that if a physiotherapist could come to my house, maybe I would be able to walk. So they are demanding this service. Sometimes although the illness and the prognosis has been communicated, but still, because this the whole cycle of, the 5 stages of grief, that sometimes they go back and forth between acceptance and denial, and they feel that the service is good, but I am not getting cured. So cure me quickly. Cure means that the disease should be uprooted, and the person should be able to function as they were functioning before the illness. So these kinds of inputs were also coming. Yeah, so this is another way of basically making a program more people-centric. So lastly, coming on to the challenges or the limitation or the question that I was going through is that because of lack of formal training courses, especially in the context of Chhattisgarh, especially in the context of for example, having a program for nurses education in palliative care in the local language was something that we did really struggle, and that's how we decided that we need to have a course for them here, and maybe in future run courses for other nurses in the area, so that they're able to understand what it is and able to provide that. Also, another question was, what is the cost of delivering palliative care integrated through the primary healthcare? Because as we spoke, that it reduces uh, cost of spending from patient side. Does it reduce cost of providing care from the system side as well? This was something that I was basically we were brainstorming among us, and this is something that we would like to explore further. Also, how to measure impact of such a program, whether to use scales or survey or use a mixed method approach, something which we have already tried, but this also we would like to explore more in coming times. So my biggest learning has been that palliative care can be delivered in an area like Chhattisgarh, in a rural tribal area, through nurse-led teams. And multidisciplinary teams is the strength. And as I said, not to fixate on degrees or people, but to understand that what roles need to be provided and who are the people in your team who would be able to provide it. And focus mostly on field-based learning, because degree courses does not actually guarantee that those skills would be translated into practice. And third one is that when we choose people who would be included in especially palliative care team, their attitudes, their values are more important than their professional degrees, because it's easier to teach a person a skill. It's more difficult to change attitudes. It's more difficult to bring in soft skills like good communication, empathy. So the attitude has to be right, the values have to be right. Fourth is that the program, uh, I think that it's more efficient if a program is built iteratively, with frequent reflections, with frequent reviews. And we have actually come up with a toolkit for similar programs elsewhere. Only thing is that if there are people who would lead the work, who would be able to take it forward, and I won't say that any degree is a criteria or a limitation, but only the will of that person, whether they are from medical background or not, is the only sole criteria that they will be able to take this work forward. And lastly, that palliative care needs to be that common thread that holds other, vertical programs together, whether it is in the public health system or in a space like NGO. This because it is not limited to any disease or illness, but rather it is a more humanized form of care, which improves quality of life, not only I would say of the person or the family, but also for the provider. So I would just finish with what we are planning to do ahead. So as I said, that we plan to build a training center with a hands-on site uh, for for Central India, and through collaboration with Pallium India. We are also looking at delivery of palliative care at the primary healthcare level through the health and wellness centers. We are also planning to include inpatient care, whether it is in the form of traditional inpatient or something like a hospice or a halfway home. And with all these additions and uh, more such components, we plan that in the coming times there would be a palliative care excellence center in Central India, which will serve as a model or a learning center or a resource center for people who are interested to start such service in their own areas of work, in their own locations. So that's what we plan to do ahead. So I would end here. Thank you so much for. I hope to connect with anybody who would love, who is keen on including palliative care, or is interested to learn more. I would be happy to connect. Thank you so much. Thanks,
Thank
Arpita.
you.
Thanks.
Thank you so much, Dr. Shilpa. Yeah. Just two questions.
Yeah,
Uh,
yeah, sure.
if you can have. So for the health workers, you said that the nurses are getting physiotherapy training before they go to the field and for home visits. Are the health workers also being trained on something specific, or is their role more iterative based on the patient's needs?
Are you asking specifically in physiotherapy?
No, for palliative care. Are you giving
Okay.
them any specific training for the health workers or?
Yes, yes. So basically, when I got trained in palliative care, I began with a very small team. There was one social worker and one or two nurses, and I started training them. So when the team was small, we were doing basically hands-on or one-to-one sessions, which were sometimes they were more like a uh, teaching them the theory, and then when went for a home visit or an OPD consultation, they would learn how to do it practically. But when now we have a bigger team, there are around 10 to 12 nurses and around that many mid-level health workers, social workers. So now what we have done is that we are doing, you know, module wise training for all of them in our center only. And apart from that, three of the nurses are being trained. They have recently finished their training with Pallium India on an
Okay.
online course. So these people would be like this training has sort of has been now like a TOT, and these nurses will now become the trainers for the rest of them.
Okay.
So this is what we usually do. We start with some basically training, and then people who have basically longer experience with the service are the ones who actually become interested in also, and
Yeah.
also they becomes the trainer for the coming nurses and batches, rather than the like a doctor only remaining the trainer and the rest of them being students. So I don't think that's a more that's not a very good way of training, because the way that a nurse can teach a nurse is
Mm.
much better than when a doctor would teach a nurse. So they
Mm.
learn more from each other. So that's what we do here.
Yeah,
Yeah,
that's true. That's what our experience has also been like.
yeah, yeah.
So, I mean, they've also included palliative care as one of the 12 packages for comprehensive
Right,
primary care for
right.
the health and
Yeah,
wellness centers. So, because you're also working with the public health system.
yeah.
Hello.
Hi, sorry. Did you drop off?
Sorry. No, I dropped off.
Acha. Yeah, yeah, yeah,
Sorry. Yeah, so with the CHOs, how
yeah.
do, because they don't have a very good support system when it comes at the PHC level or at the block level also to support them with palliative care. So,
Mm.
what kind of a role can they play right now with the resources they have available?
So I don't know about other states, but in Chhattisgarh, these CHOs are being trained in palliative care. And not only the CHOs, but the ANMs, the ASHAs, even the medical officer have had a training in palliative care. What they have done is that in each PHC and in each CHC, they have identified people who would be like the nodal of a particular program. So these people are the ones who are basically receive training in batches uh, at the state level, and then they are asked to basically implement the service that they are being trained on. Um uh, the barrier is, which we have, of course, you must have had your experience also, Arpita, that these trainings don't usually translate into practice on their own. They usually need, as you said, that kind of support, that kind of backup, because most of the health programs, are functioning either on incentive basis, and if suppose there is a so-called a mistake or an error, it basically falls on the person who is primarily involved, and they don't find support within the system. They don't find that kind of backup that they could lean on. So what we so this is something that we are going to explore in the coming years, and probably I would be able to answer that better in times to come. That we are going to start a basically a study on how to integrate palliative care. It is one of the deliverables in the comprehensive primary healthcare program. ASHA, CHO, and the MOs are supposed to deliver it. How well are they able to do it? What are the barriers? What are the facilitators? And how they can be supported. So this is something that we are looking at. But in my experience, I feel that if our nurses who are not uh, yet CHOs, if they are able to deliver care and with minimal help and support, CHOs well should be able to also provide care, because palliative care as such doesn't need specific infrastructure. All it needs is an eye which can identify people who need support, and only a will to help them, and that they will be able to do because they belong to that same community. So if they have even minimal support from their so-called department or centers, they would be able to provide much of that care. Yeah, thanks.
Thank you so much. And good luck with the training center. We are also looking forward to it because we have a lot of staff who need to be trained in palliative care.
Oh, thank you. Thank you so much. That's Thank you so much, Arpita. Yes. So
Thank
we'll
you.
do it together.
Sure.
We will need your support as well. Yeah. Thank you. Thank you so much,
Thank you so
Arpita.
much. Yeah.
Thanks. Take care.
Yeah.
Bye-bye.
Bye.